So let's start the first section, right? So I would like to introduce Professor Koto to introduce the speaker.
I introduce first speaker. First speaker is Miyahara. He graduated from Nagoya University in 1985.
95, yes.
85. And so he works. He has been a specialist of upper GI. Now he works at Fujita Healthcare. Health University. He is number one upper GI specialist. Please start lecture. Okay, Miyahara.
Thank you, Professor Goto and chairpersons, and Professor Somchai, and all attending doctors, and Fujifilm staff. It's my honor to be able to speak here. Today, I would like to talk about endoscopic diagnosis and treatment for early gastric cancer in Japan. First slide shows the incidence of gastric cancer in the world. Unfortunately, Japan has the second highest incidence in the world, while Thailand seems to be very low, less than 1/8 of that with Japan. From Japanese data, age distribution of gastric cancer incidence in Japan. As you can see, this cancer is common among the elderly people over 65 year age. As you can see this age structure, left side is Japan. Japan has large number of elderly people like this, while Thailand, not so many. But in 30 years later, in Thailand, changed to almost same situation in Japan. So I'm more afraid that same situation may occur. The role of endoscopists for gastric cancer are early detection, accurate diagnosis, and appropriate treatment, including ESD. Among of these, I believe early detection is most important to save patients' life with gastric cancer. This slide shows 5-year survival rate of gastric cancer in Japan. As you can see, stage 1 gastric cancer is over 60%. And the 5-year survival rate was 96%. So in Japan, many gastric cancer patients are detected in early stage and saved their life. However, some early gastric cancer is difficult for us to detect. We usually observe the stomach membrane using both white light image and LCI. In right side LCI, you can see clear reddish mucosa like this. In white light, I seem difficult. LCI help us to detect early gastric cancer by changing the color contrast between the red color of gastric cancer and the red color of the surrounding gastritis mucosa. This case, we performed ESD, and as you can see, well differentiated adenocarcinoma. I would like to talk about our research on the detection of early gastric cancer using LCI. We enrolled 27 cases, 31 regions of early gastric cancer. As method 1, 3 endoscopists evaluated white light and LCI the same time in recognizing the lesion border at same position. And as method 2, we compared the color difference of LCI with that of white light image. We set ROI, center of lesion and surrounding mucosa, at the same position in white light and LCI. And we calculated color difference using CI. For this case, the color difference was 21 in white light image, but 41, almost double, in LCI. Maybe you can agree LCI image is more visible. So as a result, LCI was highly visible in subjective evaluation. And the color difference, LCI shows bigger difference than that of white light. So we summarized LCI is superior in recognizing the border of early gastric cancer lesion. And because the color difference between gastric cancerous mucosa and surrounding gastritis mucosa was greatly visualized. So I ask you, do you observe stomach with only white light? With LCI, you can easily detect the color change like this. After then, we usually change BLI magnification. As you can see, this region shows irregular microsurface pattern. So we diagnosed this region was early gastric cancer, and we could perform ESD. Let's move to second topic, AI. In recent years, many papers on endoscopic AI have been reported. Now in Japan, only 3 companies have commercialized AI endoscopy system in Japan by Fujifilm, Olympus, and NEC. And Fujifilm's AI is the only one that can be used in the stomach and esophagus with conventional endoscopy, named CAD-I. This AI system is compatible with any 700 series endoscopy, not AI dedicated endoscope. This system works as detection support for upper GI in real time. I can show you 3 real cases. First case is early gastric cancer case. This patient had 2 lesions. Of course, we performed the ESD for this case, mucosal cancer. And next case, gastric malignant lymphoma, mantle cell type. A little difficult case to detect. sorry. Third case is early esophageal squamous cell carcinoma. For esophagus, this system works with BLI or LCI, not white light. As you can see, this system can detect brownish area like this. In LCI also work well. But white light don't work. Okay. Okay, let's move to appropriate treatment. ESD is an endoscopic treatment method that was developed in Japan and has become popular therapy around the world, including your countries. In Japan, the number of endoscopic treatment is almost same that of surgery in Japan. In principle, ESD is local resection technique without lymph node metastasis, so it's different from surgery with lymph node dissection. So in Japan, there is strict indication for gastric ESD. As you can see, there are percentage in each status. This means possibility of lymph node metastasis. So we can perform ESD for the region with almost 0% possibility of lymph node metastasis. We have to keep this indication to save the patient's life. And also, we have to keep the horizontal margin for each case. So if we perform ESD, firstly, we have to check the border with magnification. As you can see, there are clear border of this region according to the difference of surface pattern. After then, we can move to ESD. Usually, this kind of demarcation line matches with pathological diagnosis. Today, I have limitation of time, so ESD is only one. It is difficult for me to explain. But we usually perform ESD step by step. Firstly, the accurate diagnosis, the border of region. After then, marking on outside of region. And move to circumference mucosal cutting and dissection of submucosal layer. After then, we can get en bloc resection. Recently, the traction method has become popular in Japan to easily perform ESD. Not for expert, but for every endoscopist. Clip with line traction method is most popular. This case was type 0C gastric cancer exists on greater curvature of upper gastric body. A little difficult to keep the endoscopic view during ESD procedure. Thanks to traction method, we can see the clear submucosal layer like this. So it is helpful for us to perform ESD easily. Another case. This case was difficult case for me because of severe fibrosis. To tell the truth, This lesion was local recurrence after former EMR at another hospital. We performed traction method to get the clear subgozal view. Almost fibrosis, but we can get the good endoscopic view and perform the ESD safely. In 2009, Professor Gotoda reported the magnetic anchor-guided ESD using this kind large magnetic generator and clip with small magnet. It's very nice. So we tried simplified method using small neodymium magnets for outside and inside with clip. This video was ESD procedure for beagle dog. Clip with neodymium small magnet and outside small neodymium magnet. We can pull the lesion in any direction so we can get clear subgozal layer like this. This is my take-home message. I believe early detection is most important to save the patient's life with gastric cancer. And also new technologies such as LCI, AI, or other technologies can help us. So please try it. Thank you for your paying attention.
Thank you for Dr. Miyahara, wonderful presentation, including LCI, magnification, and traction with ESD. But discussion is after finish presentation. Thank you.
Thank you very much.